it takes many years to produce a good wine. See? It takes many years to prepare this lecture. It's a long time experience to put in slides. Thank you very much. How many of you made more than 5 reverses in your professional day life? More than 5. No, 5. 5 procedures. All right, 5. Okay. So it's a good number because we never know when we talk about reverse how many people really do the reverse arthroplasty. Again, this is my team. We are proud to be here in a group. We are 4 this year. We came from far away, very happy. Kind of feeling tired to go back 11,000 kilometers, but let's do it. I will talk now on improving internal rotation in the reverse. It's a very specific topic. It's one little thing in the reverse world. And so, here are the evidences that we can improve internal rotation. Because the bad thing is that when you do a surgery and the patient reaches here, in your trochanter, in your buttocks. The good thing is when the patient comes here, this is, at least the surgeon feels very happy. Let's see how it works. First thing, how to measure internal rotation. Let's see. In the vertebral level, that everybody does this. I just did it. Vertebral level. But also you can do with the arm in abduction and then you move this way. Or you can do in neutral position. So 3 ways to do it. Most of the authors like to do the vertebral level from butts, L5, L1, T12, T8. This is the way we can check this. So measuring internal rotation in reverse is not well reported. 30% of the studies even don't show any citation of the internal rotation. And the methods are quite different. There is no consensus in the literature. Very few studies check the internal rotation, pre and post-op. Well, so these are the factors that influence functional internal rotation after the surgery. Pre-op deficit of the internal rotation, smoking, male, gender, less distalization of the greater tuberosity, thin humeral component, and high ASA score. Like this, it's a distalization of the greater tuberosity. Those are the factors causing internal rotation deficit after a reverse. And except for the sex, all other factors are reversible. We can change everything. We can change smoking, we can change the system we use. This other paper says that repairing subscap and size of the glenosphere have no influence at all in the internal rotation. And this paper comes from Christian Gerber, who is a person well respected. This is a golden statement. Patients with good pre-op internal rotation usually have good post-op internal rotation. It seems simple, but it's not. You have to check this before surgery. So, previous diagnosis, type of implant, repair of subscap, lateralization, and notching seems that were not identified as predictor factors for internal rotation deficit, according to this well-respected paper from JCO from South Korea. This other one kind of disagree. It says that male, smoking, thick humoral component, not repairing the sub, high body mass index, fat patients, or base plate without augmentation were identified as predictor factors for deficit. So, kind of confusing one paper and the other. Here comes a very fat person, obesity, which is a pathology, and big BMI. High BMI as an independent predictor for internal rotation deficit, because these obese patients, most of the times, don't come up here. So, the bigger the body mass index is, smaller is the internal rotation, pre-op and post-op. And this, it's kind of confusing. I don't like these slides comparing everything, but just to show you, 3 respected papers, Gerber, JC, and the last one, published in a very fine journals. Big disagreement among them. You know, they kind of talk different things. So, now comes the experience, like Angelo was telling us about. Now, third step, we can correct, prevent, and improve the internal rotation. Functional internal rotation requires at least 40 degrees of extension. I always tell this to my patients. For you to reach here, first you have to go there. These 40 degrees are important, and patients can be trained for that. So preserve or increase extension is crucial to get a better internal rotation, like this gentleman is doing here. Now, things we can modify. Lateralizing the center of rotation of the glenoid in 6 to 8 millimeters increases the active internal rotation. Exactly the same paper as Angelo mentioned minutes ago. So when you lateralize your center of rotation of your glenoid, you are making a better space for external and internal rotation. Now, you can make tendon transfers in this area in order to improve your rotations, either external or internal. And this paper here shows that anterior transfer, not posterior. Anterior transfer means bringing the latissimus dorsi and teres major to the top, not to the back, is an option to restore internal rotation. It seems a simple procedure. You just detach from down there and suture on the top. And Bassin, our sex speaker, world-known person for tendon transfers, has a cadaveric studies that compare pec major and latissimus dorsi with teres major. And in his experience, still in Mayo Clinic, pec major is more efficient than latissimus dorsi to restore active internal rotation. So you have options. That's a good thing. Consider 145 degrees angle for better range of motion, including internal rotation. You all know from literature, and here is an incomplete list of models that you have in the market, ranging from 155 to 135. And so, choose 145 or 135, but not 155 for a better internal rotation. And the fourth step, can we predict the internal rotation? Like the patient is seated in front of you, and he will ask, well, my doctor, Can I reach my back after surgery? It's kind of still we don't know the answer. Let's see how the surgery goes. Let's see how the physiotherapy goes. Well, machine learning, uh, artificial intelligence, data from 4,000 reverse shoulder arthroplasty can give us 85% accuracy to predict how good or bad will be our internal rotation. So artificial intelligence, the thing that is in our Facebook, in our Instagram, in our news, it's inside our daily surgical schedule nowadays, which is very good, I think. So, how to improve the internal rotation in reverse today? Correct measurement. Understand what you're dealing with. Check before surgery, after surgery in your vertebral level. Step 2, identify risk factors, obesity, male, smoking, and previous deficit of internal rotation. 3, expertise of your surgical team. You have to be able to understand and do lateralization, tendon transfer, and very importantly, rehabilitation. And artificial intelligence is something for the future, not now, at least in my practice. Here we have a failed rotator cuff tear arthropathy, and this is a prosthesis done with this system, Exatec. And here is the patient. Please observe elevation, external rotation, but mainly internal rotation in the last film that is not running well. Patient very happy, 8 years post-op. This is another patient with a gross osteoarthritis and a very bad rotator cuff, 67 years old. And here it was implanted another system. It's what we call inverse reverse, where the head is in the polyethylene and the base is the titanium. And this is how it looks like. It looks like strange, but it's very stable. This is what we call this system. It's Agilon implant cast. It's a German design. And here are, without any conflict, showing you a presentation of Helmers, a German colleague that presented the system some time ago in Europe. They have hemi or total or reverse system that can change from each other. And here is the patient that I just showed the previous pre and post-op. I like to teach the patients in my office, and this is what I do with great pleasure, besides a good physical therapy. And here is the patient doing extraordinarily well after less than 1 year. Look the internal rotation. Look at that. It's my best patient. All others are very bad. This is the best one. I like to always show the best one, for sure. Well, finishing again, hope to see many of my friends here that I met in Cairo in few days in Rome. Thank you very much. And please be in touch. Thank you.